It's a minute after 4, and here we are with a campus-wide forum to answer questions, talk about COVID-19. We welcome anybody that's joined us. I think we'll record this and then make it available for those that are teaching class or have something else that they're doing. But thank you for those that have joined. We are so happy to have with us Dr. Dave Blodgett. Dr. Blodgett, you're kind of unique in the world of directors of public health departments. How many do we have in Utah? How many divisions?
13 local health officers like myself, yeah.
13. You're responsible for the Southwest Utah Public Health Department. But of the 13, how many are actual physicians who specialized in public health?
Yeah, I'm the last physician health officer in the state. 20 years ago, all 20 were physicians, but I am the last. So a dying breed, I guess, nationwide even.
Well, we're fortunate here to have you directing the local public health department, and with your extra expertise of having that as your specialty in medical school.
Oh, thank you. Great to be here. So I am an SUU alum, so if you want to talk about that too. So.
Yes, we always want to talk about that. You've always been helpful to us. You were very much involved in helping us make our plans for this fall as a great consultant. And whenever we do anything interesting, we get with you to make sure we're all right. And you've joined us with other kinds of things too, including giving me a collection of books to read that have been fascinating.
Well, good. You've always been very kind. I appreciate the chance to interact and support SU any way I can.
In addition to Dr. Blodgett, we've got Dr. John Anderson, our provost. And John, you've headed up, at least for the last section of our committee preparation work for this semester, and spent a lot of time along with all of the members of your committee and everybody else involved. So
we've had a lot of great minds working on this issue, and I think it's been an enjoyable effort to work on, even though the content we were talking about wasn't that enjoyable most of the time.
Yeah.
And Dr. Blodgett has been great to join us several times and give us good advice along the way.
You know, John, we might want to mention about our faculty member. Would you like to say something about that?
Certainly.
Since we're on the line right now, I think that's...
Yeah. Unfortunately, this week we lost a member of the faculty, Ganesh, and Etheridge, I think is his last name. He's Indian. And he passed away in his apartment here in Cedar sometime between Tuesday night or Wednesday morning. We have received confirmation that he died of natural causes that were not COVID related, as the president mentioned in his statement. He became ill Sunday night. He has family that lives out of town, and to talk to them, and they were caring for him. He did go get the COVID test, which came back negative after he had passed. Family member had talked to him. His wife actually had talked to him, I believe it was Tuesday night, and then couldn't get a hold of him Wednesday morning, and so called the department manager, who went and found him there. His department chair, McKay Stephenson, and his dean, Frank Hall, have been fabulous in supporting the faculty and communicating with students. We've had our dean of students involved, as well as our great counselors in CAPS have been so willing to reach out and help students and faculty through this challenging time. So we certainly regret the loss of a good faculty member, and wish his family well as they go through the grieving process.
I was adding it up, and I think that since I've been here 7 years, we've had, I think, 5, with this 6, employees who've died while they were still employed. If we include Fred Adams, who wasn't completely employed, but he was. Anyway, it seems like it happens about once every 14 months on average. So we decided that we would send out a little bit of an obituary. We've never done that before, and that's going to be our pattern from now on out. So that's what you received in your email today. Well, let's jump. Thank you, John, and we're doing everything we can to help the family. I think McKay went down and picked them up at the airport in Las Vegas, and we've arranged for a hotel while they're here. We're doing our very best to make sure that his family knows that he was a valued member of our community, and we care for him, and we are mourning with them. Well, let's jump to our topic of COVID-19. Dr. Blodgett, thank you for joining us. There's a lot of questions that we've got, but why don't we just start? Tell us what we're learning about COVID-19.
You know, I'm continually amazed at how rapidly the science around virus transmission and particularly the uptake has been with COVID over the course of this. It's kind of stunning to think about. We're really only about 6 months into this pandemic, and we're where we were about 14 years into every pandemic before this. So it's been remarkable to kind of study the science and the progress from somebody in the educational environment. There's really been a lot of lessons that have been learned and advanced the science very quickly. To be on the verge of a vaccine, and even if it doesn't come until January, 1 year for a complete turnaround on a vaccine is unbelievable progress. There's some diseases we've been trying to get a vaccine for 20 years, 30 years, and we still don't have one. And so the kind of resources that have been devoted to this has been breathtaking. There's 24,000 scholarly articles in the literature now.
24,000?
Yeah, related to COVID-19. Has just been an explosion in scientific learning and research and capacity. It's unlike anything that's ever happened in the world of science before. And so I know that's not the positive message you hear sometimes, but it really has been remarkable how quickly the scientific community has gotten behind this, and the political and economic resources have been brought to bear. And so we've just made just tremendous amounts of progress. Even just in the therapeutics and how this disease is treated has progressed very quickly. So we just don't see the kind of death rate that we saw in the beginning of this pandemic now, because quite frankly, we're just better at knowing how to treat it. And sometimes that's what you need, is a little time to figure out how to treat this, a disease. And so some pretty basic things have made a real difference in how well people do with this disease. Adding a course of steroids, for example, and not putting them on a ventilator. It turns out one of the worst things you could do for somebody with COVID is put them on a ventilator. And so that progress has been really dramatic, as well as just kind of some societal dialogues and understanding about how disease spreads. And I think there will be a better understanding of, we've been talking about for decades the fact that influenza A kills more people than anything else in the United States from an infectious disease standpoint. We've never really been able to get that discussion to move forward, but now I think people understand the principles of how a respiratory tract infection spreads, and we might even see decreases in that arena. So it's a remarkable time to be in public health, to be learning about all of that, to be in the medical field. There is the downside, which is the scare and the uncertainty and what happens if you get it. But there is this idea that, we're learning more and more, so that we'll be better prepared for the next one as well. So, thank you.
What are we learning about symptoms?
Right. Well, so this disease it really depends on how old you are, if you have underlying medical conditions. If you are young, like most of the people in this audience, probably in the college arena, the symptoms are very mild. Can be anything from resembling a cold, a common cold, to kind of pneumonia looking kind of thing with a cough and fever and all of that. That's what we talked about in the beginning of the pandemic. But for most people that are in this age range of 18 to 30 kind of range, it's very mild, and maybe a little bit of a fever for a day or so, and maybe a headache. Some people get headaches, but mostly it looks for all the world like a common cold, or some people describe it as allergies. They think they have allergies. And I think that's created some difficulties for people. I mean, the real task we have is to keep the people that are most vulnerable to this disease from getting the disease. And so if you are not in that high risk category, it might not seem to be so important to not get sick with this, but it always has to be in the back of your mind that you don't want to spread it to somebody else. And so being really diligent, particularly if you say have a side job working in a nursing home, or you're going to go see your grandparents or something like that, being really diligent about, hey, anything that looks like a viral illness of any sort, I need to really be diligent about not exposing somebody, just in case. So
We have faculty and staff online listening to this. And what would you say about symptoms for somebody that's my age, 60?
yeah, so even in the older age ranges, we've learned now, they've done seroprevalence studies here in Utah, and those from the CDC came back and said, look, it looks like about 11 people have had this disease for everyone that was tested and that we know about. And so there's a lot of people that have very, very mild illness, even in some of the people we've taken care of that are in their 80s. It seems to be that if you have an underlying medical condition, that is the people that are most at risk. And so there's multiple phases to this disease. There's the initial viral phase, which looks like anything from a common cold to maybe a flu-like symptoms with aches and pains and headaches and fevers, that kind of thing. That's cough that we talked about in the beginning. About 50 to 60% of people have this deep cough because it's beginning to head into the lungs. But that's not the phase when people do the most poorly. It's after that first week. Sometimes in a certain percentage of people, they kick over into this overdramatic immune response phase. And that's when people begin to get shortness of breath, they can't breathe, they really feel they're wiped out, they lay on the couch and can't get up, kinds of things. And they can go down dramatically, in a dramatic fashion very quickly. And there's several syndromes in medicine that they can develop at this phase of the disease, and that's really the scary phase. And so in some ways that's created difficulties for us because we don't know how to test for people that will end up having this dramatic immune response. And often people don't feel bad enough to get tested in that first week, and so they'll show up in the emergency room with requiring oxygen and rapidly end up going to the ICU. So that's the dramatic phase, and that's the one that we worry about and that people need to be worried about. So you might feel fine for the first week. It's the second week when the dramatic presentation happens. And that is an immune response mediated activity. It's not necessarily the virus. In fact, sometimes we'll test those people and they don't even have any virus left in their system. They test negative, but it's clear that they're responding to COVID. It's not unique to COVID. It's similar things happen with a brand new strain of the flu and other diseases. It seems to be just certain diseases have the ability to trigger this over response in the body's immune system.
Speaking of tests, do I understand that we now have the saliva test here in Iron County?
Yeah, so IHC system-wide has gone to a saliva test. So you no longer have to have somebody stick, a nasal swab as far back to scratch your brain as possible, but saliva much easier. So we're hoping that that'll make things better.
Is the saliva test comparable in its accuracy?
Yeah, I think it's so you got to remember the PCR test will pick up as few as 10 particles of virus. So it might it might take an extra cycle or two to get there to test positive, but it will pick it up even out of saliva at just as high a rate, almost exactly the same sensitivity and specificity. So that's good.
I like the idea of a saliva test better.
Yeah, I think everybody does now.
Um,
I think advances in testing are going to be important as we go forward. We've had these PCR tests, which are expensive. They're difficult. You have to have an adequate sample, and difficult to perform and have to be done in really high level laboratories. But on the horizon, we'll see antigen testing coming out, which will look for the virus using antibodies, but will allow for much easier modes of testing, much more rapid testing. The idea that's being promulgated by a lot of people is called lick a stick, right? So maybe everybody could have a supply of 20 of them at home and test themselves every day before they go to school, or out as a screening test that you could confirm with PCR. But it would be much easier to have readily available testing instead of this 3-day delay and all the difficulties that we're facing with testing now. So that's on the near horizon. It shouldn't be too long before that happens. And I think that will be a real game changer as far as we will be able to open almost everything up, because there will be capacity to test people in lots of things. So maybe you could test people before they come to school, for the day, or if somebody's worried they might have something, a readily available test that's not as limited in quantity and as expensive as what we have now is going to be really, really important. And I think it's coming. So.
Some of the things that we've heard about the saliva test is that it is not as accurate as the nasal test, but that because it's easier to get, more people will take it. But I don't know if those things are accurate, which...
Yeah, I think it's comparable. I don't think it's so far off that I'm concerned about them. We've been researching them just like they're. But in all of these tests, they're far more specific than they are sensitive, and specificity is important. So specificity tells you if the positive test is really positive, so you don't have false positives. There may be a few more false negatives with decreasing sensitivity. But the increased frequency, if you can test people more often, will overcome that. And really, if you look at the curve of infectivity, when somebody's infectious and not infectious to the disease, you want to be able to pick them up when they're infectious, right? And so this incredibly sensitive test that picks up 10, 15, 20 base pairs or 20 particles of virus is really overkill for the purposes that we need them for, to be able to go to school, for example, or go to work or something like that. You want to know if they're infectious. And so the ability to test more rapidly and more cheaply will be really much more in line with what we need to know. And you can confirm it with these really accurate PCR tests. So you don't get any false positives or false negatives. But the screening aspect of that is really appealing. And I think we've been really hung up on the idea of got to have it, 99% sensitive and 100% specific. And I think you could do just as good a job if you had something that was 89% sensitive and 95 to 100% specific, and it would accomplish equal to the task of what you're trying to accomplish, but be much more accessible.
Speaking of tests, so a couple universities in Utah have been testing wastewater coming out of their dorms. John, you may want to comment on this too. We made a decision not to do that, and part of the reason is because the majority of our students don't live in our campus dorms. We don't have access to the vast majority of our dorms or where people live. So we're, but talk to us about that.
Yeah, so we have that data available for all of the communities around. They sample Division of Water Quality at the state Department of Environmental Quality does that testing, and We haven't found the data to be very helpful for us. It gives signals, and we don't see a corresponding rise in cases in that area. And I think it's pretty problematic, actually. I know they did it at Utah State. They quarantined some kids, but now you're in the practice of quarantining a bunch of kids that aren't sick, right? And probably won't be sick. You just have a kind of an inkling that somebody there was sick. And I think that gets into a realm that's, I think it's iffier. I mean, I think if you can document somebody's been exposed, there's a reason for that person to stay put. But if you can't, and you just have well, you were somewhere in the vicinity kind of inkling, I think that's just more problematic. And you don't want to shut down your whole university just because there's somebody somewhere doing that. And so I haven't found it to be as useful as our traditional, who were you in contact with, contact tracing, testing, those kinds of, they're calling it the Tetris approach, and that is consistent. Maybe it can give you an inclination that there might be an outbreak coming, but I just haven't found that data to be very useful in my experience.
John, you've got the numbers from how many people are tested at SUU. Maybe you could relate those. And then Dr. Blodgett, I'd be interested in your response to what that.
Sure. Just one comment on the wastewater. USU, Utah State, is the primary institution that's doing that. And they use it as a leading indicator. And so if they find wastewater, they then go in and test everybody in the residence hall. We don't have residence halls we only have 900 beds total. And they're fairly large residence halls. We have lots of beds in one building. And the testing is incredibly expensive. And so our model of contact tracing, when we do have a positive test, I think has led us to a pretty good spot without the overexpense of wastewater testing. And we get our numbers from various sources. We have lots of people who self-report to us when they have a positive test. We also get data of people who have had a positive test who reported to Southwest Public Health. They then share us with the names with us of the positive cases. We then compare it against those who have self-reported to us to make sure we're not double counting anyone. In the last 3 weeks, 3 weeks ago, we had 9 total cases reported. Last week, we had 8 total cases reported. This week, we just turned the numbers into USHE today, and we have 6 total cases to report. Now, those numbers represent our SUU community at large. We don't know, or we can't know, but we don't track how many of those are on campus and how many of those are face-to-face, but 6 out of a total of nearly 13,000 students is not a strong presence for the case, for the virus here on campus.
The number of 8 for the week prior, I think I heard that we know at least one of those students lives in Japan.
That's correct.
Taking classes online. So while some people are clearly getting this and not being tested or not reporting, some are getting this and reporting it, but they don't live here. So it's interesting. Dr. Blodgett, what does this mean for us, these kind of numbers? And I was looking at the website that you've got that reports all of the numbers in Southwest Utah by county. Talk to us about what those numbers mean.
Well, the numbers are always just an indication of presence of the disease in the community and gives us kind of a qualitative feel for how much is there. I think they're excellent numbers for SUU. If you would have told me a month ago when SUU was getting ramped up to get started that we'd only have that many a week, I would have told you, nah, it's not possible. So I'm really, really thrilled actually with all of the efforts that SUU has done to keep those numbers down. And we know, you've probably tracked that there's been a big outbreak of the universities in Utah County. And we know from that experience and from what we've been tracking there that there just isn't a lot of spread from on-campus activities in classes, those kinds of things. It's the social things that go on outside of campus that is spreading the disease. And so So I think it's an indicator that maybe the message is out there better, that people are taking it more seriously here on SU campus, that people understand the nature of how this disease spreads. And so we just don't have the kind of explosive growth in the number of cases that they're seeing in other universities in the state. I think it's a tribute to SUU, to the students and faculty there. I'm grateful to be able to say that. It's always one of those waiting for something to drop kinds of moments, and we have to maintain diligence and just be aware and keep it in the back of your mind that it's there. But so far, so good.
Is you mentioned it, and I think that we would all agree that 6 in the last week is a real surprise. I was thinking it was going to be much higher.
Yeah.
But
Yeah, even at that, this age range is the number one group that we see cases in our area. But our district, the 5-county area that I represent here, and Iron County particularly, has been right in that kind of 5 cases per 100,000 range for about the last 3 or 4 weeks, which is a great range to be in, low prevalence in the community. And I think that's consistent with what you're seeing cases at SUU. So it's good.
I was talking to a friend of mine who's a president of a university in Colorado, and he told me that the University of Colorado Boulder has 1,300 students who are sick right now.
Man. Yeah.
And that must be a lot of off-campus activity.
Yeah.
We've been super
parties.
grateful. Yeah.
Well, and so we're aware of this phenomenon we'll call super spreader events, for lack of a better term, where just we get unlucky, right? Somebody's at the peak of their viral load, they go and they expose 100 people all in the same night because they're at a party or something, and that's what ends up exploding the numbers across the campus. And so that's the worst case scenario, and I think it's happened in several universities here, and sounds like in this university in Colorado. So
I think he froze halfway through Colorado.
visual to it.
Dr. Blodgett, we missed you for a minute. Are you back?
I am. Am I?
We just lost the last of that thought.
I apologize.
No, it's good. I thought it was me, actually, because it happens to me all the time.
Shoot. I just got the notification. We must have had a little glitch in our internet here. I apologize.
No. But this,
So I don't know where I made it to what I was saying, but we worry about the super spread events when somebody's at the peak of their infectiousness and they go out in a big group and infect everybody there, and that starts the widespread spreading within a group. So just keep that in mind. That's why masks are part of the recommendation, is they help you keep your droplets to yourself instead of sharing them with other people. So.
are we learning anything more about masks and social distancing?
Well, it's clear 6 feet is the distance that really is almost magical. Being outside, if you're outside, you're 19 times less likely to spread this disease. And masks make a difference. If you are sick and you are not spreading the droplets, this is a droplet spread disease, then you're just much more less likely to more likely to not spread, or less likely to spread the disease. So those recommendations are fairly well vetted now, and I think they make a lot of sense. Wash your hands, stay home if you're sick. That's the biggest one. If we could just get people to stay home when they're sick, that one is the number one on my list. Stay 6 feet away from people as much as possible. Wear a mask. That combination, I think, will go a long ways towards keeping the numbers low, keeping school open, keeping all the activities going.
How about the droplets on a surface?
Yeah, that's a great question. So in theory, most of the time when we talk about droplet spread, we talk about fomite spread as well. So the droplet ends up on a surface. The evidence is just not good that there's much of that that happens. Some, a little bit, enough that it's worthwhile to still wipe things down and be cautious, washing your hands and those kinds of things. But it's not the primary driver behind this. Primary driver is being within 6 feet for more than 15 minutes. So social situations in your family, around your roommates, those kinds of situations. That's where this spread happens 85-90% of the time. When we call people up and we talk to them, we say, well, do you think you know where you got it from? The vast majority of the time people say, oh yeah, my sister came into town and she called me later and said she wasn't feeling well. And so those kinds of encounters.
The, um, how seasonal is this? What can we what can we expect going into colder weather?
Well, I think so. We've seen, continued cases through the summer, but coronaviruses are just seasonal viruses like the flu. And so I think we'll see an uptick as things cool down, people congregate inside more. I think in the end, this will be just as seasonal as the flu. We'll see it every year coming around. So I think that's kind of a warning pause. I'm glad you asked that question, to be a little more diligent about this. I told you that one of the best things you can do is be outside. And it's hard to be outside when it's cold like it is here in Cedar during the winter. So just being aware that poor ventilation areas, being close to each other inside, those are better areas for the spread. And temperature seems to really play a role in all of these seasonal viruses. They charted where all the big outbreaks happened in March, and it came along a band of a fairly narrow temperature range. And I think we'll see that again, and we tend to be in that temperature range. So I'm worried that we're going to see more cases, and I think that will highlight the need for a little extra diligence as we, implement those kind of basic personal measures to avoid the disease.
We just need to not get casual because things are
Yeah.
going well.
Yeah, I'm hoping the vaccine comes to save the day, but I'm not thinking it's going to come before the next wave. And so you just got to be aware of it.
If someone is tested positive, here's a question that was submitted. If someone tests positive, how long should they remain quarantined after the test?
So when we call and talk to these people, and I think so we try and call everybody, but sometimes we don't get people and they don't answer their phone or whatever. This is the current recommendations. 10 days from the start of symptoms, but you need to have 1 day without any symptoms at all. So it could be longer than 10 days if you still have symptoms at 10 days, but at least 10 days. That's the standard for everybody.
What's the difference between an aerosol type versus a droplet type?
So droplet is a larger version of aerosol. It's all on a continuum, right? And so the question is, and aerosols stay suspended in the air for long periods of time. So there are certain viruses that are virulent enough that when you cough it out, it stays suspended in the air. And so, for example, measles, if one person coughs in a room, everybody in the room gets exposed and they'll get sick if they haven't been vaccinated or had the disease. Droplet spread diseases, though, tend to need a larger number of particles, and they tend to only be active when they're in larger droplets that drop out of the air fairly rapidly once you cough them out. So they don't tend to stay suspended in the air for long periods of time, and they don't tend to be able to infect people unless you're directly in contact with those droplets from another person. So it's a little bit of a subtle difference on a continuum, and I think that line gets blurred, and so you're seeing some of that discussion in the literature and on the news right now. But it's pretty clear that the vast majority of this happens from spread by droplets. And you can tell that because you don't have a lot of instances where somebody coughed in a room and everybody got sick, like what happened with an aerosol disease, but it's mostly that 15 minutes within 6 feet kind of scenario. And so it's fortunate, those diseases that spread really, really rapidly through a true aerosol transmission are, we'd all have been sick by now, and I guess we'd be on the other side of it. So it just spreads just that much more rapidly.
Yeah. What about spring?
Yeah, spring that'll be good. It warms back up, and we'll see a change towards less transmission. The other part of the summer that's good is vitamin D levels increase. So get out and get your sun, get lots of sun before the sun is gone. So.
When do you think that we might see the second wave? I'm reading a couple questions that came in that.
Yeah, I think SU is smart how they're approaching this. So you're going to send everybody home at Thanksgiving and then do finals online. Is that what I'm understanding? So
Yep, that's right.
I think that makes a lot of sense because I think that's about when that second wave will be in full swing. So that'll be good.
When would you think that would continue to?
Well, if it's consistent with the waves that we've seen, it'll be about a 6 week from the beginning to the peak kind of wave. So about 2 to 3 months for the whole wave to go through. So let's say it hits maybe mid-November. You'd expect it to be done maybe mid-January kind of thing. So maybe in time for school to start back up. So
We'll at least have a lot of information as we get closer.
Yeah, and we're getting much better at this disease. The longer this goes, the better off we are. And we just have a lot better understanding of what's going on.
I'm running through some questions coming in from our faculty.
Yeah, that's good. I'm happy to answer them.
We were talking about droplets versus aerosol. We always see people walk around with their masks on, and then occasionally somebody that's got it down below their nose. What does that?
Yeah. Yeah, that's not proper mask wearing. I do see it more often than not. It's true. When you think about it, what you're trying to do is keep yourself from delivering droplets to other people, and so that's just one more route that the droplets get out. So the debate sometimes centers on whether or not you're protecting yourself by having a mask on. I think it does to a certain extent. It might not be 100% like, say, an N95 mask would be, but certainly lessens that infectious dose and maybe gives some protection, which I think it probably does. And so it's just a little bit of the armor that's let down. Probably most of the droplets would come out of your mouth, but when you think about it, if you have an upper respiratory tract infection, it's your nose that reacts the most strongly, and you got your mucus and all that stuff. And if that's down below there, you're not going to be protecting anybody. So it's not proper mask protocol.
I think you just answered this question, but how much does the mask help us in not getting infected versus not spreading it?
Yeah, some people want the mask to be the answer to all the questions, and I'm not convinced that's true. But I think it is part of the overall solution. It's one piece in the quiver, and I think it definitely is one of the more consistent methods that we can use. The distancing is clearly the best thing that we can do, and being outside. But I'd put it in the third spot there after those other two things, and then maybe hand washing after that. Maybe first of all is to stay home if you're sick, but somewhere in that realm. People have tried to put numbers on it. It's 40% effective and those kind of things. I don't think you can do that, but I think it certainly is a valuable part of the idea that we can stop the widespread of this disease.
I've got a question here, and you've commented on this about the fact that this isn't spreading on campuses or in classrooms. We aren't seeing any evidence of that happening. What we're doing on our campuses is requiring faculty members and students to wear masks in class,
Yeah.
but they aren't all 6 feet apart. So
Yeah, I mean, I think you're left with the masks really work, right? And keeping people out of there. So if you're symptomatic, not going to class is the best thing you can do for somebody, right? And so being very careful to monitor yourself before you get around people is really important. And like I mentioned earlier, sometimes it's a lot milder than you think it's going to be. And so even if you think it's just allergies or something like that, it's still worth being considerate enough to consider the option that it might be COVID.
is the mask and 6 feet, I mean, if I'm wearing a mask inside but close to people, or staying 6 feet apart?
It's still preferable to stay 6 feet apart, but if you can't, then the mask is your line of defense. Yeah, great question.
Let's see.
Combing through the questions to see what's next.
Yeah, that's what I'm doing.
There's a couple questions that relate to our academic calendar that I can address for just a little bit. Some have asked, if the wave is going to go to mid-January, why don't we postpone classes online or when we start spring semester for the first few weeks? We've really deferred most all questions about calendaring for spring semester for about another 4 to 5 weeks until we have really good data on where we are. And so we haven't taken anything off the table yet, but the numbers don't really justify us pushing anything back or changing any delivery format for spring at this point. If that changes, we'll certainly revisit it. But at this point, with 6, 8, 9 cases a week, I think our current measures seem to be addressing the need. There's another question about our good faculty member who passed away, and if symptoms come up 2 weeks later or during the second week, how do we know that he did not die of COVID? His test, his symptoms, all of those things were within about 4 days of each other. And so that test should have been accurate when he was most likely to have the virus in his system. And that result came from the medical examiner. So we're fairly confident in what that decision was.
Well, and I think it's, there's a lot of information that's not shared.
Mm-hmm.
But the medical examiner made the determination that it was natural causes, and all of the reasons for that determination are things that we don't know. But what we do know is the test was negative, and the medical examiner said it was natural causes.
That's not what the medical community is being accused of either, right? So everybody's saying, oh, they're bumping up the numbers to make it look worse. And so this is an opposite charge for people to say, oh, I just don't think you look for COVID there. So they did a thorough job, and they just didn't find it. So
what do you, once a person tests positive, do they develop immunity? Are there strains where you're subject to getting it again?
Yeah, so no, there's lots of good data coming out on immunogenicity of this disease. And don't say that word fast, you can get yourself in trouble. And so we know that almost everybody that gets this disease creates antibodies, much like the response to other disease, that those antibodies wane fairly quickly, but they do for almost every disease, right? So the question is there still an immune memory there? And the answer is, yeah, it seems to be a durable memory that is created. Now, whether or not it will be like other coronaviruses where you can get the virus even every year for those 4 common circulating coronavirus strains, but it's much milder every time you get it because you've got a track record with the disease. So they become common colds, right? So there's four common strains of coronavirus that account for about 30% of the common colds that we get every year. And in some ways, that's not a bad model for immunity, right? You get vaccinated, you create an immune memory, and then if you ever get it again, it's the common cold. It's not anything dramatic like we've been experiencing with COVID. And so it is creating a very good immune memory in vaccinated people as well. It might turn out that the immune response is even more durable from the vaccine than from the bug itself. Which is not an uncommon occurrence because when you think about this disease, if you have a mild disease and it's largely localized to the upper respiratory tract, maybe you have a runny nose or something like that, that doesn't tend to create the kind of widespread immunity that you would see if you get an immunization, which is designed to trigger all components of the immune system. So B cells, and T cells, and antibody, all the full range of the response. So if you get sick, do you have an immune memory? Yes, the CDC now has data to confidently say that you won't get sick again within 90 days. They have documented a couple of reinfections. They have been rare. And in those cases, the person that got sick the second or was infected a second time had no symptoms. So that's a very common scenario with somebody that has an immune memory. And then if you have the vaccine, then it will short circuit, or you don't have to go through that first illness, and you'll be in much further down the cycle. And hopefully it will be a lasting immunity. This is not like influenza, which changes so much that you need a new shot every year. It's a very stable virus. I know you hear about mutations, but all viruses mutate. The question is it mutating in a place that's significant for immune memory? And the answer is no, it hasn't changed the characteristics of this disease. It is unlikely to. So measles is very similar to that. The same vaccine that was created in 1958 is still being used for measles because it still works, because the disease hasn't changed. And I think coronavirus will be very similar. So I don't see a scenario where you have to get vaccinated every year for coronavirus like we have for the flu. Could be wrong, but it seems like this will be a one and done. It is probably going to be a 2-shot series, so you have to get 2 shots when you get vaccinated, about 28 days apart, but it won't be you have to do it every year kind of vaccine like we do with flu.
2 questions. One, what would be considered an exposure? And then I'll wait for that. I'll wait for the next
So exposure is within 6 feet of somebody that has the disease for more than 15 minutes. Generally, we call it a lower risk exposure if both of them have masks on, higher risk exposure if there isn't a mask there. But always that's the definition we use when we're trying to find people that need to quarantine or get tested and those kind of things.
What's our current recommendation for quarantine those that have close contact? And part of that question relates to like classrooms.
Yeah. So you've caught me in a little bit of a decision moment. So currently the recommendation is 14 days out of school to watch for symptoms and to avoid spreading it to others. Just right now, though, the state and local health officers and the USHE and others are considering a change to the requirements so that if you test at 7 days after exposure and the test is negative, then you can come off of quarantine. So I think there'll be a change in policy within the next week or 2.
And I'll just jump in and add a few things that we're doing with the protocol right now. If someone has a roommate that is symptomatic, we're asking that whole room or residence hall, not the full residence hall, but those who live in the rooms, the roommate and those things, to quarantine until the test results come back. And we currently have 11 people who are waiting on test results in that category in our on-campus housing. So that number has not been very high. And those low-risk exposures that may happen in a classroom, we're not asking people to quarantine at this point. So just those high-risk exposures when people live with someone who's testing positive, that's what we're doing.
What are we doing in classrooms?
In classrooms, if there's a positive test, we ask the person not to attend class for the duration of the disease or the virus. We don't quarantine the rest of the class. The numbers become pretty problematic. If you have one positive test and that person has 5 different classes and the faculty member is also considered to be exposed by that one person, we have a class of maybe 20 times 5. So immediately, as soon as one test comes, we have 100 people just from the classes that student was a part of. Then if you add to that those who the other classes the faculty member may teach, with each positive test, we could be quarantining 400 or 500 people. And so all we do is quarantine the one that has the positive test and then tell everybody else to watch their symptoms carefully. And if there's any symptom that comes up, don't come to campus.
Dr. Blodgett, your reaction to that?
Yeah, so that's consistent with the idea that mask on mask exposure is very low risk, and also consistent with our experience that we just haven't seen a lot of spread in that environment. So I think that's consistent with how we've planned and the way it should be.
Is asthma still considered a risk factor?
You know, it really isn't. I think it can be, but generally the underlying conditions that place you at highest risk are related to what we call metabolic syndrome. So the number one risk factor, and we don't talk about this very often, is obesity. So if you have a BMI of 30 or more, which puts you in the morbid obesity category, your risks from this are higher at every age range, all the way down. Along with that comes a whole host of other things: hypertension, diabetes, heart disease. All of those carry a higher risk. Kidney disease, for some reason, tends to be really high risk as well. But really, asthma hasn't proven to be nearly the risk factor that we thought it might be.
What can a person do to strengthen their immune system to make them less at risk?
These are better questions. I like that. So eating healthy, the typical college diet of pizza and ramen, probably not going to cut it. So throw in a few extra vegetables in there. I mentioned vitamin D earlier. There's a lot of really great research coming out that says if you have adequate levels of vitamin D, you're much less likely to trigger from that just virus into that overimmune response phase. So I recommend people, take a little vitamin D. So 5,000 units a week, or maybe 1,000 a day. Extra milk, something like that. Getting outside. So generally, the recommendation is 20 minutes of sun exposure every day of some sort, if you can get it. So get out, ride your bike, walk to class, those kinds of things. That's all helpful to kind of build up that vitamin D level. It seems to make a big difference. Exercise 20, 30 minutes a day, doing all of those things that are healthy, make a big difference in how people fare for this disease.
How about blood clots? Can you talk about the long-term effects of COVID? What are we learning about that?
Yeah.
Blood clots or all those things.
Great. So part of that immune overresponse is a hypercoagulable state called disseminated intravascular coagulation, so DIC. And it's not exactly DIC, but it's related to where the cascade of factors that influence your immune system also triggers your clotting mechanisms to activate at the same time too. So it shows up in the person as nosebleeds and inability to clot their blood. But the truth is that all of the factors in their blood that can clot have clotted out. And so you end up seeing strokes in young people, not incredibly common, but some. And so most of the protocols when they treat people in the hospital are beginning to include anticoagulation kinds of things, heparin and those kinds of things. So when people call me and ask me, well, what does my regimen look like if I thought I had COVID, I would add, or I would keep in mind that idea of looking for things that might indicate that you might be in a hypercoagulable state. And sometimes, so nobody knows exactly how much anticoagulation would do the trick here to stop some of that stuff from happening. And so, in somebody that's asymptomatic and mild, it's probably much less than somebody that's in the hospital where they would give you the really big guns like heparin and stuff. So there's some pretty common anticoagulation agents that are readily available to people, but the most common one I would say is maybe take an aspirin or just an aspirin or two, every day if you think you might have had COVID for a week or so. That's not in the scientific realm, that's in the whatever. Now there is this other question of what about people that tend to have symptoms that last a long time? And it seems like there is a sizable portion of people that end up with severe disease that even after they go home from the hospital, they end up having prolonged symptoms. The most common is this unique phenomenon we have in COVID, which is loss of taste and smell. That can go on for some time in some people. Some people it's a week and they're done. Some people 3 months later, they still don't have their taste and smell back. And so that's the most common element that stays. But then there's some of these other, shortness of breath, just not feeling quite themselves, achy. Sometimes people report some psychiatric complications, maybe depression or anxiety. I think that's something that needs to be explored. It seems like there's more likelihood to do that if you end up with severe disease and you end up in the hospital, and less likely the younger that you are. But there seems to be some of that in almost all age ranges. So I don't think it's well defined yet, but certainly something that's coming more and more to the forefront as we get further into this outbreak.
In Iron County, since this started in March, there's been 3 COVID-related deaths, according to your statistics. What is there that you can tell us about that?
All of them fit into either the category of over 70 or having underlying medical conditions that would significantly contribute to being more likely to die from almost any disease. One of them is well known in the community, had end-stage cancer and was on hospice. So that most of the studies indicate that about 50% of the people that have died from COVID would have died within 3 to 6 months, even if they had not contracted COVID. And so those are the most vulnerable, those people that have those underlying medical conditions. I will also say that all of them had severe obesity as part of their makeup, their underlying morbid conditions.
Here's a question. Any chance Southern Utah will be moved into green?
Yeah, man. I wish
probably half the people listening want that to happen and half of them don't. I don't really know.
Yeah, the governor released new guidance on what it takes to move to green, and what he wants is less than 100 per 100,000 active cases over a 14-day period, less than 10 per 100,000 on a 7-day moving average active cases, and less than 5% test positivity. So Iron County is right on the bubble on all of those. We have about a 6% test positivity rate. We have about a 11 or a 12 on the per 100,000 over 7 days. And I think we have 120 active cases over the last 14 days. So we're right on the cusp, but our numbers are going the wrong way. So I don't think we're going to hit green anytime soon. But we were close. We made it close.
Let's see. We don't have any more questions, except for one of the viewers said, "Thank you for your leadership at this very weird time."
Thank
So this has
you.
got to be an interesting time to be a director of the health.
Yeah, I'm not sure. I thought that this was what was going to end up happening to me when I signed up for this gig. So, but it has been exhilarating to work with everybody and see the community come together. One of the things I worry most about is we seem as a civilization to be losing our civility sometimes. You know, Facebook is something about the anonymity of social media allows people to say things that are unkind and untrue and don't really help with the dialogue. And maybe one of the lessons we can learn from all this is being our best selves always makes it better for whatever we're going through. And I salute all of those that I've been able to work with that have done that. A lot of really hard work has gone into this. I think SUU particularly has been a model on how to approach this and done a wonderful job. I'm really grateful for all of that.
You've been very helpful to us as we put together our plans for this fall and as we make continued plans for spring. So thank you so much.
Thank you.
Are there, what concerns would you give us as we continue to make our plans?
Well, I think we're in the phase of COVID fatigue. I think that's understandable. If I have one plea, it's that, you know, we really want to be about protecting those that are most vulnerable and keeping that in the back of your mind. You know, it's one thing to think, well, it's not going to really impact me very severely, which is maybe true in the college age, but it doesn't mean you want it, right? You don't want to get sick with anything you don't need. but it also, at least stay home when you're sick so you don't spread it to others, and be very, very careful around those that are vulnerable. I'm aware of several stories of, you know, little old ladies, 85. They did a good job of isolating themselves, had their groceries brought in, did all the right stuff, but their kids came to visit them and they couldn't say no to their kids. Kids came in and ended up giving them COVID and they end up dying. And that's just something you don't want. You know, that's the group we need to be most concerned about. So.
John, what have you got?
This has been very helpful. I really appreciate your time, Dr. Blodgett, and I appreciate your direct responses and willingness to answer a whole host of questions. So thank you. And I think I would just echo, as a campus community, the faculty, staff, and students have really responded. Our student association has taken a real leadership role in getting students on board to wear masks and to watch themselves and to not come if they're symptomatic, and that's been incredibly helpful. I'd like to publicly thank them for their work. So thanks for being here, and thanks to all of you in the SUU community who have been part of the solution.
Yeah,
Okay, we're out of questions. There's a couple more comments of thanks to you, Dr. Blodgett. So thanks for
thank you.
Your kindness, your help, and we feel fortunate to have you here.
Well, it's been a good thing. So if you need anything from me, let me know. Be happy to do it again.
Okay, thank you, and everybody have a great night.
Enjoy. Thanks, everyone.
Bye. Thank you.